And before giving the word to you, Professor Arminio, I would like to thank you once again for what you have done for our country. We are deeply thanking you for that. Thank you. Então vamos aqui.
And Professor Arminio Fraga is very close to the National Academy of Medicine. He has seven relatives that were member of the academy. His grandfather, his father, and some uncles, and also some very close relatives. Then Arminio has grown in this house, and of course you are very welcome again. And thank you very much for accepting our invitation.
Thank you. It is for me a great pleasure and an honor to be here. I have been here many times, mostly as a kid, and I'm glad to be back. I have been asked to talk about economics and medicine. But I'm actually going to talk about economics and health more than medicine. I'm not a doctor, and I'm not a scientist, or well, maybe an economic practitioner, but it's not quite the same thing. So let me start with some basic numbers so that we have a sense of what it is to be talking about. I think they are very much along the lines of what we just heard. First, a couple of numbers on Brazil. As we just saw, this is an enormous sector, and it's around 10% of GDP. It includes services and say goods. It is the largest sector in the economy. If you want to think of economic development, which is sort of my passion, it is undoubtedly one of the two most important ingredients in a successful growth strategy. The other one, of course, being education. In studies that we have done in the Institute for Health Policy, IEPS, Instituto de Estudos para a Política de Saúde, a not-for-profit independent institute based here in Rio, we have worked out some numbers, and our view is that the health sector will grow over the next couple of decades by another 4 points of GDP. This is enormous. And this is based on trends in technology, also includes a simple fact also that people, as societies age, they spend more in health and so on. A lot of that is part of public policy, and this is a great challenge. I will get back to that at the end. It is a sector that generates a lot of jobs. It is a sector that is at the core of technological development, innovation, and so on. So this is point number one. We're talking about the obvious role of health in the development of a nation. Unlike medicine, which deals with individuals and tends to be more reactive, although we always think of medicine also as being, and it is, focused on preventing issues. But unlike that, when we talk about health policy, we're talking about the social dimensions, first and foremost, and it includes all kinds of interesting other neighboring disciplines such as behavior psychology and so on. Why public health? My general third point. Public health really has to do with very important issues of social well-being, but also social insurance, if you will. By that, I mean, it is very important that individuals can feel minimally safe if they are faced with a major health challenge. So this is in the world of insurance, social insurance. Public health also plays a very important role in the challenge of inequality. And I don't need to tell you, but inequality here in Brazil is massively, it's just gigantic. Moreover, public health addresses some very important issues in economic theory. The economics of the health sector are very, very interesting and very difficult. And the issues usually revolve around two words, technical words: adverse selection and moral hazard. Adverse selection has to do with the building health systems and the simple fact that people who know more about themselves than, let's say, their insurer, they tend not to buy health because they think it is expensive. And you end up in a system where only the worst risks tend to sign up. And thus, the importance of having something that is universal or that at least protects the system from adverse selection. This may be a little too technical. But there is also moral hazard. The word is technical. It's not really about moral in the sense, in a philosophical sense. Is in a behavioral sense. People, if they feel they're covered, they're less careful. That kind of thing. Smoking in bed, this sort of thing. So point number 3. This is a growing field in economics. What we have seen over the last couple decades is quite simply that this is an area where there is abundant data to use. And because we now have no limitations on our computing capacity, we can use gigantic databases to do research that develops, I believe, solid scientific support for good health policies. So this is a very good, it's a wonderful field. We at YAPS have been, because we understand the databases, they're not very user-friendly. We have been attracting a lot of interest from international researchers who come here to do work for us, really, basically. Lots of it for free. And they're very good. So this is sort of general third point. Why public health and so on. In the world of public health, my fourth point, there are two general approaches. And they tend to be known as the Bismarck approach. Bismarck being famously the first to really build social security systems, excuse me, and the beverage system, the famous beverage report in the UK. And Brazil has opted, or tried to opt, excuse me, for the British system, which is a system of universal and publicly funded health system, unlike beverage, where you had mostly insurance being provided by companies. This doesn't work for Brazil for a lot of reasons totally, because about 45% of our workforce is either unemployed, about 7% now, or in the informal sector. This is also enormous. The surprise, if we look back to the Constitution, and despite what was designed or written into it, is that in Brazil, we find private spending in health being larger than public spending. It's just a fact. There's no ideology in this comment. But it is surprising. The share of private spending on health is close to 55% of all health spending, and is larger than the share even in the United States. Yeah. So this is a surprise. Point number 4. We can think of health issues in sort of different categories. For example, there are external factors. What do I mean by that? Okay, a topic of the day, climate issues, environment issues. So we're talking, for example, in Brazil, water and sewage. This is an area where we are going, hopefully, through a good beginning of an investment cycle that could go a long way, but where roughly 50% of the homes in Brazil do not have adequate clean water and sewage. This is a very simple system to put to work with private capital. Why? This is a little bit of economics. Because it is really trivial to monitor clean water going in, sewage going out, and sewage being treated. So you can write a contract that can be very easily enforced. And I think this is going to go a long way. This is a phenomenal response. There are other sectors where this is not quite so easy, including parts of medicine, by the way. Another external factor is epidemics, in a way, and what to do about it. Here, I think we have a lot to show, and this is clearly a phenomenal success of the public system of SUS, and despite the efforts of some high-level politicians, not really to defend the universal vaccination of people, but people were smart and they ended up listening to people like Professora Margarete Dal Como, and they took their shots. This is for our visitors to know. That was pretty good. Okay, now we have also behavioral factors, and here I'm thinking about tobacco. I don't know how many people here know, but the statistics on smoking in Brazil are phenomenal. They are probably the best in the world, I would say. Are they? Are we? Yeah, so it went from 40% smokers to 10%, which I'm going to guess, and I'll be, of course, humbly listening to Dr. Margarete. But 10% is really, really, really spectacular. Now, other issues, obesity, in particular, also child obesity, major issue. We now know that a lot of calories don't really provide health. They can actually go the wrong way. You eat the wrong calories and you end up with all kinds of problems. Idleness, talking about sedentarismo, another one. Drugs, alcohol, and so on. Okay, now a little bit more so I can conclude without taking too much time. Where are we in terms of SUS, the universal coverage, free system that we are so proud of and we should be. What we have is, at the moment, a situation where the system is, and has been for a long time, but at the moment, we are, I think, beyond under financed. It's just unbelievable. And let me give you the numbers here so you know what I'm talking about. We spend close to over 8%, 9% of GDP on health, and SUS gets the universal, again, the supported in the Constitution as being universal and free, less than 4% of GDP. Now, just to give you a sense, if you look at the UK, the income or the GDP per capita of the UK is about 3 times higher than ours. And this is taking in account purchasing power. Okay, so purchasing power parity numbers, Brazil spends, well, okay, our GDP, they spend 8% of their GDP, we spend 4%. So they spend twice more, 8% of their GDP per capita. Because their GDP per capita is greater than ours, the system in the UK spends 6 times more per capita than Brazil. 6 times more. Okay, that's the arithmetic. 6 times more, and they're in a crisis. So we spend 1/6 of what they spend. Is very tight. What does this mean? This means that the priorities in our budgetary procedures are completely out of place. We have, in Brazil, we spend about, the government spends about 1/3 of GDP. Okay, quite a bit more should go to SUS. This is primary spending, okay, it doesn't include interest. This should go towards the numbers I presented here. And I think a lot of the growth should go into the public system. This doesn't mean you cannot have all kinds of interesting governance experiments and so on and so forth. I can't get into that now. But this is something that really troubles me. And I think it should. There are other issues, the use of technology, strategic elements that were presented just now here by Felipe, industrial policy, and so on. But the lack of priority in our budget is just very, very evident, and something must be done. This is going to be very difficult. There are other areas that are lacking. Let me give you one last set of numbers. Over the last 30 years or so, government spending in Brazil went from 1/4 to 1/3, okay? From 25% of GDP to 33%. So public spending went up 8 points of GDP. Public investment went from being at the peak 5% of GDP to less than 2% of GDP. So you would think, if I had asked you before I gave you the numbers, okay, spending went up 8 points, what do you think happened to investment? You would say, okay, it went up also. No, it went down. Another example of a lack of priority in our budget. Okay, now, to conclude, a couple issues that I think are a corollary of what I just said. First, the issue of what to do when you don't have enough resources is very difficult. Here you're talking about ethical issues, because if the British system puts limits on what they spend on, imagine us. And if we don't do that, then the solution is driven by the simple fact that there's just not enough to get the job done. Okay, so the solution is completely suboptimal. I think we need to face this. And I think if we face it, we may then also go back to the budget and say, hey, folks, there's a lot of stuff we could be doing here that we're not doing. So it's very important. It's an educational issue. I think this is going to be a very difficult battle. Lastly, there are significant inequalities also in our federations model. Brazil is a federative republic. We have states, cities, public health is provided at the city level for basic health and at the state level for, call it, hospitals. And the problem is the spending in health, think about basic health, just to finish. The funding of the system of primary health comes from a fraction of the tax revenues of each city. Now, the average income of each city in Brazil is massively dispersed. There is immense inequality. And I was just talking to Felipe a little earlier. Take the case of two cities right next to us across the bridge. We find two cities. One is a 1 million person city called São Gonçalo, quite poor. Right next to it, there's another city called Niterói. Niterói is actually quite prosperous. It's a lovely, lovely city. And the spending per capita in São Gonçalo is a third of Niterói. A third. There are some redistributive mechanisms, but they don't do that much. In education, they do a bit more, which is quite good. So this is another issue that is part of this inequality that troubles us so much and that is so challenging. So anyway, this is what I have. I'm delighted. I at one point in my life, I thought I was going to be a doctor. You know, my father brought me here as a young boy, and it was kind of planned because I had family here, as was mentioned. I ended up doing something else, but I'm very happy as I now kind of move to I don't know, the last quarter of my professional life. I'm to be 67 soon. I'm just very happy and very excited about the work we are doing in this area. Doutora Margarete Dalcomo has been incredibly generous to be on our board, and we just feel we have a lot to do. And what I hope with this very short, brief talk is to tell you that we economists understand that health and medicine are very important, and we are at your disposal with the tools we have to see if we can help. Thank you very much.
Thank you very much, Professor Arminio Fraga, and I have really appreciated what you have said, and I'm more than sure that you can very much help because it's needed. I can assure you it's very much needed, and I think everybody which is here agree with that.